Into sports medicine, and just like the review text and the sports medicine review text, we'll cover it starting with the knee, because really the knee is the starting point for arthroscopy and for a lot of sports medicine. And so even though it doesn't flow anatomically from top to bottom, the knee is a good starting point, and we'll go from there. And hopefully today we'll be able to cover all the lower extremity, saving the upper extremity and total shoulder arthroplasty for tomorrow. So I appreciate your attention. I know this is a tough course. I know it's tough to sit through all this, and we'll try to make this somewhat enjoyable. So first of all, sports medicine is not rocket science, and I think we all recognize that. Sometimes we tell people we have to take them to school, and so it's a matter of how you spell that. So again, we'll start with knee, then cover lower extremity today. Tomorrow we'll cover more of the upper extremity, as well as some of the head and spine questions that appears in sports, primarily concussions. And then some of the issues about being a team physician, which is important as far as drug doping and stuff like that. Some of the stuff you see in the newspaper more and more and more. So let's start off with knee injuries. First of all, a little bit about anatomy and biomechanics. I know that we're going to cover that some in the anatomy lecture, but it's important to recognize that the ACL and PCL cross, as names would imply, and they form this so-called four-bar linkage that's been described by Amos and others. In addition to those cruciates, we have the collateral ligaments, medial and lateral. And then what was very confusing to me in my residency, and now has become a lot more clear, is the so-called posterior medial and posterior lateral corner, which we'll discuss in some detail. So you know the knee is a diarthroidal joint. It allows both simultaneous rotation and translation, and that's why it's somewhat difficult to figure out, and that's why it's susceptible to arthritis if everything's not working correctly. It has articular cartilage, which we learned from the basic science. It involves type 2 cartilage. Type 1 cartilage, ONE, is harder cartilage, like bone, B-O-N-E, ONE 1. The cartilage has mostly water, and it has increased water and decreased proteoglycans with arthritis, and that's a test question that occurs commonly, and so it's important to understand what happens with arthritis. The ACL itself goes from the tibia to the lateral femoral condyle. It's about 3 to 3.5 millimeters wide, 11 millimeters, long, and 11 millimeters wide. And as Freddie Fu will tell you, because it's in USA Today and everywhere else, it has 2 bundles. And so typically we've just worried about one of those bundles, but it's becoming more and more popular to talk about the 2 bundles of the ACL. Now, both the anterior and posterior cruciate ligament are supplied by the middle geniculate artery. The PCL goes from the medial femoral condyle to the tibial sulcus. It's a little longer and a little wider than the ACL. We know this has 2 bundles, and it's always asked on questions about the anterior lateral bundle. And the anterior lateral bundle is your PAL, P-A-L, PCL, anterior lateral bundle. ACL, anterior medial by exclusion then. So the PCL has the anterior lateral bundle, which for years we've concentrated on fixing because it's the most important bundle as far as flexion. PCL, anterior lateral bundle, tight in flexion. The PCL's role is in flexion. And so the PCL, the anterior lateral, is your PAL. Remember that. Now remember the lecture on musculoskeletal radiology. We saw the meniscofemoral ligaments. One goes in front, one goes behind, alphabetically Humphrey in front of Rissberg, Humphrey in front, Rissberg behind. Again, the middle geniculate artery is the primary blood supply. How about the medial collateral ligament? Well, it goes from the medial femoral condyle and inserts in a long strip all along the medial tibia. It has both a superficial and a deep component. The Houston Clinic nomenclature, which has confused residents for decades, still hangs around and lingers around, unfortunately. And therefore, they call the superficial component of this the tibial collateral ligament, and the deep component of it the medial capsular ligament. But the rest of it, just call it superficial and deep. The lateral collateral ligament is a very stout cord-like ligament that's tight in extension. It goes from the lateral femoral condyle to the tip of the fibula. Now, it's interesting that this ligament, although biomechanically not strong, is very rarely injured in and of itself. It's usually only injured in combined ligament injuries. The capsule on the lateral side, its most distal extent is just posterior to the fibula, and that showed up on some questions. So again, that question about putting the pins across the knee, you want to go at least 1.8 to 2 centimeters below the joint line to avoid getting into the joint. Otherwise, you risk infection. Well, how strong are these ligaments? Well, in general, people used to say the PCL was twice as strong as the ACL. We've learned later that's really not true. It's a little bit stronger, but not twice as strong. The MCL is the strongest ligament of all. And the LCL, even though it's rarely injured by itself, is actually the weakest of all of the ligaments. What about the layers? And there's been a lot of press about the different layers in the knee. I think it's important, if it helps you to organize your thinking about where things are, to think about this layer concept. And you think about the fact that you have superficial structures such as the sartorius, and the superficial MCL and semimembranosus is more deep. And then the deepest structure of all is the capsule, or the deep MCL. The deep MCL is really just a thickening of the capsule. How about the posterior lateral corner? This is the most confusing of all. Well, it's really not so confusing if you just think about it in two layers. Really, superficially, you have the biceps tendon, and you have the iliotibial band and tract. And then deeper, you've got the lateral collateral ligament, the popliteus musculotendinous unit, the popliteal fibular ligament, which goes from the popliteus to the tip of the fibula, and really the posterior lateral capsule. So that's really what's there in the posterior lateral corner. Patellofemoral joint, our favorite. It really increases the moment arm for the quadriceps. It's fully engaged, about 40 degrees of flexion. And this is the issue, is even though it's the thickest cartilage in the body, it's sometimes susceptible to injury because 3 to 5 times the weight of the body goes across that joint. And that's why when you have an extremely large patient with extremely severe patellofemoral pain, you have to encourage them to try to get their weight in ideal body weight so they don't have so much trouble with that joint. The patella is really divided into medial and lateral facets. Rather than learning these 7, it's probably easiest just to think of it in that way. And to realize, and more press is occurring in this, and this is therefore probably more and more testable, is the importance of the medial patellofemoral ligament. It acts as a check rein to lateral patellar displacement. So I suspect that you're going to see the medial patellofemoral ligament on your boards. Here it goes from the superior aspect of the patella over to the adductor tubercle. It is immediately adherent to the vastus medialis obliquus. In fact, if you dissect this, you need to reflect up some of the VMO so you can appreciate this ligament. This is a real ligament. It does exist. The meniscus, the menisci are crescent-shaped. Only the peripheral of the meniscus is vascularized through the medial and lateral geniculate arteries. The medial meniscus is more C-shaped. The lateral meniscus more semicircular. And the medial meniscus has broad attachments to its horns. The lateral meniscus has attachments to its horns that are very close to each other and very close to the ACL. The menisci serve to deepen the tibial surface and act as a secondary stabilizer, especially the posterior horn of the medial meniscus, which is the primary secondary stabilizer to anterior translation. That's an important thing to remember. The meniscus is composed of 2 different kinds of fibers. The most important fibers by far are the longitudinal fibers. These longitudinal fibers allow hoop stresses to be transmitted across the menisci. And also, it's important to capture those longitudinal fibers when you're doing a meniscal repair. Hence, the benefit of doing vertical mattress suture, the strongest repair possible in menisci, because you're capturing those longitudinal fibers. In addition to the longitudinal fibers, you have radial fibers that tie those in. The meniscus is made out of type 1 collagen. The meniscal excursion is also something important to remember, and that is that the lateral meniscus has twice the excursion on dynamic MRI than the medial meniscus. And so it's important to remember that. Again, the attachments of the horns, lateral real close together near the ACL footprint, medial far separated, which has implications if you want to do transplants. And so the transplants typically for the lateral have been troughs or bone blocks. And on the medial side, traditionally more plugs. Well, what about the classic history and physical examination? Well, we're all familiar with these classic findings. This patient presents with these stories, and it really helps us to make the diagnosis most of the time. If somebody has a pop and swelling and non-contact pivoting injury, their knee blows up like a balloon, then it's very likely an ACL tear. In fact, 70% of the hemarthroses will be ACL tears, 70%. If you get hit by a blow to your proximal tibia, either by falling on the ground with your foot plantar flexed, which is what allows the tibia to impact the ground, then you're very likely to have a PCL injury from a force from the tibia forcing back to tear the PCL. If, however, you fall with your foot dorsiflexed, then the moment arm is going to shift up to the patella. And that's why a fall with the foot dorsiflexed will cause patellofemoral problems, patellar chondrosis. If you have mechanical symptoms, locking, catching, maybe you have a meniscus tear or a loose body. And if you have pain with stair climbing and sitting in a theater for a long time, then they're not supposed to be in my clinic. Now, how about the examination? Each injury has a classic examination that you need to focus on. And whether you know 15 exams for one injury or whether you know the classic one is really not important. For the boards, if you know the classic exam, that's going to hold you in good stead. So, ACL injury, the classic exam, the gold standard is a Lockman exam done in 20 or 30 degrees of flexion. From a practical standpoint, I like to put a pillow under the patient's knee, helps them relax, keeps them in that 20 or 30 degrees flexion. You can put your hand and feel that their hamstrings are being tensioned, and then simply do your Lockman. A pivot shift exam is helpful too, but it's really only helpful under exam under anesthesia, or if you happen to be lucky enough to distract the patient long enough to do it, only once. Now the PCL exam, the key exam, is the posterior drawer exam, done in 70 to 90 degrees of flexion. And when you're doing that exam, the first thing you've got to do is feel where the medial tibia plateau is. On this side here, there is a medial tibia plateau step-off anteriorly. On this side, it's flush. That's because that patient has at least a grade 2 PCL injury because he's starting with the tibia plateau and the medial femoral condyle flush. That's a grade 2 injury. If you can push the tibia further back, then it may be a grade 3 injury. But the key exam is the posterior drawer, and the key for that is assessing the starting point. So don't get fooled by not knowing where the starting point is, thinking the patient has an ACL because he's really starting off posteriorly subluxed and you can pull him forward. You're pulling him forward to the normal position. The other test that sometimes gets too much press, I think, on OITEs and other exams is the quadriceps active test. All that means is you're sitting there laying supine, your knees flexed 70 to 90 degrees, and you ask the patient while you're sitting on their foot to kick it out. What that does, it pulls the tibia forward and recreates your normal step-off point. In other words, it recreates the tibia pulling forward to its normal position from its subluxed position, and that's a quadriceps active test. Medial and lateral collateral ligament injuries are assessed based upon valgus or varus instability. This test is done in both 30 and 0 degrees of extension. If you have opening only in 30 degrees of extension and not in 0 degrees of extension, you likely have an isolated medial collateral ligament. If you have opening in both 30 and 0 degrees, then you have at least one and maybe two of the cruciates involved as well. Now, the other test that's really important, I think, is going to show up on boards for sure, is external rotation asymmetry. That is the test, the dial test, that's essential for you to make the diagnosis of posterior lateral corner injuries. We're starting to get posterior lateral corner injuries more and more because we're finally recognizing them. During my fellowship, I never did a single one. Now I do at least one a month. And so the key here is to assess external rotation asymmetry. And you simply do that by either lying the patient prone and rotating their foot, looking for their thigh-foot angle, or having somebody help you stabilize the knee while it's supine and external rotating the foot. You do this test at both 30 and 90 degrees of knee flexion. If it dials only at 30 degrees and not 90 degrees, then you very likely have an isolated posterior lateral corner injury, or possibly a posterior lateral corner injury with an ACL tear, more likely than not. If you dial at 30 degrees and 90 degrees, you have more than 15 degrees of asymmetry both at 30 and 90, then you very likely have a combined posterior lateral corner injury and PCL injury. And you confirm that then with your posterior drawer. So it's very common for posterior lateral corner injuries to be shown up with one or the other cruciate ligaments or both, but rarely do you see an isolated posterior lateral corner injury. But if you do, then it'll dial at 30 degrees and you'll have a normal Lockman and a normal posterior drawer. Now, the meniscus exam, the key is joint line tenderness and then some type of provocative maneuver, whether that's McMurray or Apley's compression or duck walk or what have you. Patella exam for instability, apprehension is the key. Here we see external rotation asymmetry, the dial test. Here we see pivot shift. Here, actually, it's a reverse pivot shift. We'll go over that in one of the test questions. And here we see the quadriceps active test. Again, starting in a subluxed position, the tibia is pulled forward and it goes to reduced. Subluxed to reduced with quadriceps activation. How about imaging? We've had the very nice lecture by Tim Sanders about this. I want to go over a few key issues. That is the lateral capsular sign, Sagoned injury, highly associated with an ACL. Rarely do you see this, but when you do, you can be certain it's an ACL tear. Old calcification of the MCL, Pellegrini Stiati. High riding patella can be associated with patellar instability. Low riding patella or patella baja associated with a stiff knee or arthrofibrosis. Fairbanks changes, squaring, ridging, narrowing, associated with arthritis. Fairbanks did not describe sclerosis, but that's another finding as well. Osteochondritis dissecans, very commonly, most commonly occurs lateral aspect mediofemoral condyle. Lateral aspect mediofemoral condyle. Widened or cup-shaped outside can sometimes be associated with the discoid meniscus. But the most common finding with the discoid meniscus is the MRI sequences, 3 sagittals in a row. If any exam shows you 3 sagittal enemies in a row, you better make sure it's not a discoid meniscus because more likely it's not. There's no reason for them to show you 3 in a row otherwise. Well, how about stress radiography? Two questions occur in this. Number one, you have kid with open physis. You're not sure if he's got an MCL or a growth plate injury. So you do a stress exam, varus valgus stress exam, see if they open up in their physis. The other time you do stress imaging, becoming more and more common, and in fact is going to become the gold standard for evaluating posterior cruciate ligament injuries, is an assessment of posterior translation with PCL injuries. Now it's interesting because we've done some work in the lab, and you cannot have more than 12 millimeters of posterior displacement compared to the other side unless you have a combined PCL and posterior lateral corner injury. So an isolated PCL injury will give you 10 to 12 millimeters of posterior displacement, but a combined PCL and posterior lateral corner injury will give you significantly more than 12, up to 20 or 25 millimeters of posterior displacement. So if you have severe posterior displacement when you're looking at your posterior drawer, be very suspicious for combined PCL and posterior lateral corner injury. Likewise, if you have severe Lockman that you can almost reduce the meniscus over the condyles, be very suspicious for combined ACL and posterior lateral corner injury. Now, the MRI, of course, is very helpful, helping us for meniscal and ligament diagnoses, and also this bone bruise or impaction injury, which occurs, as Dr. Sanders says, as a pivot maneuver. Well, really what it is a momentary dislocation of the knee, and it actually impacts the lateral aspect of the lateral femoral condyle in the back of the tibia. That's why you get a bone bruise, because this is what the mechanism is. And so you get a bone bruise there over by the sulcus terminalis, right here, or deepening of the sulcus, and you get a bruise in the back of the tibia, as you would expect. Note that this bruise is in the middle portion of the lateral femoral condyle, anterior, middle, posterior, and is quite lateral, and the back of the tibia. You really can't have an ACL intact knee in an adult with that injury. How about arthroscopy? Well, we're all very familiar with arthroscopy. It's a good portion of our business, and the anterior lateral portal is our primary viewing portal. If you have a posterior horn medial meniscus tear, then the recommendation is for you to look at that not only from the anterior lateral portal, but also drive the scope back into the back of the knee. Look to the medial side, create a portal in the posterior aspect by putting a spinal needle in first, localizing it, and do a nick and spread so you don't cut the saphenous nerve or vein, and put a portal in there and look in through there for a knee scope as well. So if you have an MRI that says posterior medial meniscus tear, you look at the regular scope and you go, I can't see any tear, then you probably ought to put your scope back in the back in the posterior medial portal and make sure you don't really have the tear. If you're looking at patellar tracking before or after you do some kind of patellar stabilization procedure, you may want to get a superior or far proximal portal. From a practical standpoint, the way that's done, knees and extension, you drive your scope up to the anterior lateral portal, put a spinal needle either medial or lateral way up there, and figure out how far up you can get. Then make a small incision up there and put your scope cannula in there, and that allows you to visualize from the top, bird's eye view, down as you see the patella tracking. So it's a very helpful portal I would encourage you to experiment with. Meniscal tears are the most common injury. It is the most common procedure done by orthopedic surgeons taking part 2 of their boards. 29881 is the top #1 procedure listed. And so you'll be doing a lot of scopes and meniscus surgery. Try to preserve as much as you can if you do that, and still try to repair them if you ever can. Otherwise, you're going to give your total joint, fake joint colleagues more business than they need. Meniscal tears have a high risk in ACL deficient knees, and that's why in younger people we recommend doing ACL reconstructions. If you take all comers, medial meniscus tears are more common than lateral meniscus tears. However, in acute ACL injuries, lateral meniscus tears are more commonly associated with those scenarios than medial meniscus tears. Again, all comers, medial more common. Acute ACLs, lateral more common. And the most common location in the older population is a degenerative posterior horn medial meniscus tear. You've got to be careful with that nomenclature these days because of that New England Journal article, and perhaps you're better off calling it a complex posterior horn medial meniscus tear. We do a partial meniscectomy if you can't repair the meniscus. So your first goal is to look in there and say, can I repair this meniscus? If you can, then do it. If you can't, then you have to do a partial meniscectomy. And that's in a situation where you have a complex tear, or if it's just simply irreparable, deformed, or degenerated. When you do a meniscectomy, try to remove the least amount of meniscus possible because the arthritis risk is directly proportional to the amount of meniscus you leave. Thermal is probably mentioned only to blast it because thermal injury has had multiple problems in sports medicine. Do not use heat probes. If you use heat probes on the meniscus, it may look nice and trim up that other meniscus. The problem is it can cause cell deaths, adjacent meniscus, and adjacent articular cartilage. And therefore, if you're still using thermal devices routinely, I would suggest that you change your practice habits before you take part 2 of your boards. The other issue is that the MRI is not always telling you the truth, and not everybody has a Tim Sanders to interpret their MRIs for them. So be careful, because your radiologist, if he's just a regular radiologist, not a musculoskeletal radiologist, may call intersubstance degeneration a tear. He may call the transverse meniscal ligament a tear. He may call some of these other funnies anterior horn medial meniscus, anterior horn lateral meniscus tears when in fact they're not. And so be very suspicious of tears in the anterior horn, and be very suspicious also if you can't see that tear communicating with the surface on the MRI, then you're not going to see it in the scope. How about repair? Well, we try to repair them whenever we can. The best candidate, peripheral red tears that are 1 to 4 centimeters in length, with a combined ACL reconstruction. For some reason, when you fix the ACL at the same time, you have an enhanced meniscus repair. It may be because you're releasing pluripotent factors during your drilling, or it may be because that's the way the tear is. That kind of tear occurs when you have an ACL tear. It's not clear. Regardless, what is clear is that an ACL-deficient acute ACL injury, the meniscus repair does better. So stretch the envelope in that setting. The meniscus heals by inflammatory cell infiltration. It's enhanced by grasping, and there's a variety of techniques. Keep in mind the strongest is the vertical mattress suture. What are the risks with this traditional inside-out suture? Well, on the medial side, we know the saphenous nerve and vein are most likely at risk, and that's because the needles are often poke or tied over these structures, and therefore, from a practical standpoint, before you tie the sutures on the medial side, you get a fine hemostat spread and make sure you're not tying over any round structure. If you are, pull it on both sides of the same structure. On the lateral side, the biggest risk is the peroneal nerve. So if you're doing a meniscus repair, your patient wakes up with a foot drop in the recovery room, you better hope your anesthesiologist put a block in him because otherwise you're in trouble. From that standpoint, the way you protect that is retractor placement. The retractor is placed in front of the biceps tendon, behind the lateral head of the gastroc. If you do that, you can visualize the needles coming out, and you will not puncture the popliteal nerve, or peroneal nerve, because the peroneal nerve is injured by just inaccurate retractor placement. So, bottom line is, on both sides of the knee, put the retractor deep to the head of the gastroc and visualize your needles coming out. You'll be fine. But from a testing standpoint, those are the common at-risk structures. Well, how about arrows and darts? Well, there's been a host of problems associated with this, so the old-timers that write the boards will be more than happy to point that out to you. So recognize that these arrows and darts have had a lot of problems in the literature dating back for at least 5 years, so I think it's fair testable material at this point. They can break, they can migrate, they can cause chondral injury, which is the most severe, and they're not as strong. The strongest report, the strongest device is the double vertical or single vertical mattress suture because it captures those longitudinal fibers. Well, what about a device that's bioabsorbable, strong, low profile, iatrogenic, efficacious? Well, it doesn't exist yet, and therefore vertical mattress sutures is still the best way to go. And so from your board standpoint, 2005, if you have a chance to repair meniscus on the boards, I recommend you do it with vertical mattress sutures. Meniscus transplantation, the goal here is to avoid doing this in grade 4 chondrosis because it's going to just scrape away that meniscus. Despite what you heard in some of the recent podium presentations, for your boards, do not put meniscus transplants in grade 4 chondrosis. It'll fail. The other thing to recognize with meniscus transplant or cartilage procedures is to try to make sure your mechanical alignment is corrected before you go do these soft tissue procedures. Meniscus transplant, if you've done it, you know it's technically difficult. It's tough to get those plugs in, and the long-term results are not really clear because the meniscus, even though the periphery will heal in, it sometimes doesn't function normally, and so we don't know the long-term results of this. Again, medially we use bone plugs, laterally bone bridge, and then the peripheral sutures as shown here. And they do good, they heal nicely, but the question is, do they function? We don't know that long-term. How about meniscus cysts? We touched on this in the radiology lecture, and keep in mind that almost all meniscus cysts are associated with horizontal cleavage tears of the lateral meniscus. So what happens is the fluid percolates in through here, one-way valve occurs, and the cyst occurs right here. And so the way that we can decompress those is to do a partial lateral meniscectomy, access those two leaves, go in with a shaver or a basket and spread, and allow that fluid to egress. You can also stick a spinal needle in from outside in to also encourage that to egress. So the treatment for meniscal cyst is partial meniscectomy and arthroscopic decompression, not en-bloc resection. Well, how about the discoid meniscus? There's 3 flavors of discoid meniscus. 1's incomplete, 2 is complete, like this example. It covers the entire surface of the lateral tibia plateau. 3 is a Risberg variant. That may or may not be a discoid meniscus. All it means is there's no peripheral attachments, no coronary ligaments, and therefore that meniscus is too free to move. It moves more and it can snap and pop. And so if you run across a discoid meniscus that has no tear in it, leave it alone. If you run across a meniscus that has too mobile, hypermobile meniscus that has no coronary ligaments, then do a meniscus repair and create coronary ligaments. If you run across a discoid meniscus that has a tear in it, then like any other meniscus with a tear, you need to do a partial meniscectomy. Partial, mind you, partial meniscectomy, not complete. Now again, the discoid meniscus they'll show you on your boards will have 3 successive sagittal images. If you see 3 successive sagittal images of the knee, that's your answer. Osteochondritis dissecans, the key here again, it occurs in the lateral aspect of the medial femoral condyle. The other key is if the patient has open physes and is minimally symptomatic, stop there. Don't do anything operatively. Only operate in adults or kids who are exceedingly symptomatic and failed conservative management. What about articular cartilage injury? Well, we all know there's a variety of methods to take care of articular cartilage injury. Focal defects. We're not talking about arthritis. We're talking about focal articular cartilage defects. These can be treated with a variety of treatment options, some of them more controversial, and therefore they won't make you pick between Oates and microfracture because the literature says they're roughly equivalent results, or for that matter, Oates and ACI because, again, the literature say they're roughly equivalent results. So be familiar with the different options available, but they're not going to get you into picking between those. How about osteonecrosis? Well, you have your standard osteonecrosis, kind of like you have in the femur and humerus, that has a wedge-shaped defect, and you can do a core decompression just like you do in the hip. And then in the knee, there's an unusual kind of osteonecrosis called spontaneous osteonecrosis of the knee, SONC. This is a weird thing that can occur sometimes in middle-aged patients, often following an arthroscopy. And it has to do with subchondral insufficiency. So you go in and you scope a knee and you trim a little meniscus, but the patient's also got some degeneration. They come back post-op and they are punishing you because they're complaining of pain so much. That's very likely a SONC, and very likely in your MRI you'll see these kind of subchondral insufficiencies as shown here, and the treatment is to put them on crutches and make them wait several months for that to recover. Don't go back in and scope them again. Well, how about synovectomy? Well, for synovial processes, arthroscopic synovectomy, if done carefully and properly, can be just as efficacious as open synovectomies. It's just that you need to remove all that synovium. So in order to do that, you'll need extra portals. And so don't be afraid to make superior portals and posterior portals. in order to do a complete synovectomy. And then it's just as efficacious for RA, PVNS, hemophilia, etc. Plica. Plica occurs on too many Part 2 board examination lists. Okay? Plica is overdiagnosed and it is overdone. However, the entity does exist when there's a thickened band that rubs on the medial-femoral condyle, and you can see objective evidence of abrasion of the medial-femoral condyle. Patients have tenderness above where they would have tenderness for a medial meniscus tear. Then this responds to resection. But again, the diagnosis is overused. Let's get into some ligament injuries. The ACL is a very common ligament injury. It occurs from a non-contact pivoting injury. Patients will describe a pop or hear a pop, and they'll have an effusion. Dale Daniels' classic article, patients showing up to the Kaiser system with knee effusions, hemarthroses. 70% of those turn out to be an ACL. The patients will present with a quadriceps avoidance gait, kind of a bent knee gait, avoiding their quadriceps. The exam, the gold standard is the Lachman. The pivot shift is helpful, particularly with exam under anesthesia. Recognize for any of these pivot shifts or reverse pivot shifts where the knee is going to be lax. So recognize that in a pivot shift, the knee is lax in extension. And so as you go from extension to flexion, it will go from a sublux to a reduced position. And the opposite occurs with a reverse pivot shift. In a reverse pivot shift for a PCL deficient knee, the PCL is deficient in flexion. So as you go from flexion to extension, it goes from a displaced position to a reduced position. And so it's just a matter of thinking those out. So don't have to be gimmies anymore on those questions. Well, ACL, you can't just put stitches in it. It doesn't work. And that's been shown for a variety of years because the ends are covered by myofibroblasts that basically have smooth muscle covered in, smooth muscle actin. And so those caps allow you not to allow it heal. Won't heal. You can't sew it up. So you've got to reconstruct it. In fact, all the medical students that come in my service say that this patient had an ACL repair, and I say that's not possible. It doesn't work. We did an ACL reconstruction on that patient. Subtle but important point. Again, we talked about the association of meniscus tears with ACLs, very common, up to half the time, and acute injuries, more often lateral than medial. Well, what do you do about treating ACLs? Well, contrary to popular belief, every single person doesn't get an ACL reconstruction, just most. And so we do non-operative treatment for patients who are very low demand, a little older, have less laxity. The one thing that Dale Daniels' work and subsequently Fithian's work has shown, that the patients with more higher demand activities, higher Tegner scores, where they're more active in sports, and the patients with more laxity on KT1000 are more likely to get in trouble with an ACL deficient knee. And so in that population in particular, you need to do ACL reconstructions. If you don't do ACL reconstructions and patients remain active, then they're very likely to get meniscus tears and chondral injuries down the line. Do they get arthritis? Well, that's a very controversial issue and best probably avoided because, in fact, the Dale Daniels article and the Fithian article both recently have suggested that those ACL reconstructed patients actually get more arthritis. Well, why is that? Well, maybe because they're more active. At any rate, the reason it's very controversial is because of that very issue. So recognize it's the meniscus and the articular cartilage injuries that need to be addressed and not the arthritis when you're talking about patients about ACLs. Which graft do we use? Again, huge controversy, huge studies. All of them show roughly similar results. The one thing to take to stead is the fact that the patella tendon graft, autograft, will cause a higher incidence of anterior knee pain. Because that's one of the least controversial of all of these findings, then that's probably a testable item. So make sure you know that. It's not surprising because you're taking a piece of the patella out. The other thing that's clear is in the initial fixation strength, not the initial strength of the graft itself, but the fixation strength of the hamstrings is weaker than the patella tendon. And that's why if you have a young, aggressive person who wants to accelerate their rehab, maybe that's not the best choice for them. The other thing that's not controversial is that allografts do carry a risk of disease transmission, including HIV, which is 1 to 1 or 1 to 1.5 million, and a higher risk of hepatitis. The other thing that's clear is preconditioning of grafts, regardless of graft choice, can reduce stress relaxation, in fact, up to 50%. And that's why we have these various commercially available graft boards. If you use allografts, you have the risk of disease transmission, bacterial transmission. You can reduce that by processing your allografts. One way to do it is to radiate it. Well, if you radiate up to 3 megarads, you might be able to kill HIV. Unfortunately, if you radiate that much, then you're going to kill your graft also. And so therefore, there's a big controversy about whether to radiate, whether not to radiate, etc. The bottom line is that recognize that most radiation available doesn't kill HIV. And therefore, probably the best is to sterilely harvest these grafts and to not irradiate at high doses. Also, freezing can destroy the cells. This doesn't appear to adversely affect grafts. And we do know, however, that allografts have a longer incorporation time. This has been studied by Jackson in Long Beach, and he showed in an animal model that you have a delayed incorporation of the allografts. So as far as ACL, a summary slide goes, late arthritis is related to the meniscus integrity, and therefore you should try to preserve the meniscus whenever possible. You try to work on motion early, and in our ACL population, we emphasize extension early because you lose extension and all is lost. So don't let patients go away from your recovery room, go away from your surgery center with their knee, a pillow under their knee, and come back a week or two later and their knee still has a pillow under it because you're going to have loss of extension. And so emphasize extension early, especially if you have combined medial side surgery. For example, the patient has an ACL MCL, or the patient has an ACL and a patellar dislocation. Regardless, if you have a medial-sided injury, you're at higher risk for your knee getting stiff, and you need to emphasize motion early. The other thing to do is to avoid isokinetic quadricep strengthening at 15 to 30 degrees during early rehab. And the reason for that is that puts the most stress on your graft. What are some of the complications of ACL? Well, probably the biggest complications is inaccurate surgery. And so tunnel placement is a big problem. Typically, patients will show up with anteriorly placed tunnels because the people that did it don't understand the concept of putting the tibial tunnel back in the posterior medial aspects of the footprint, and they don't understand the concept of completely clearing out that lateral wall so that you avoid the so-called residence ridge and you get your graft as far posteriorly as possible. The other risk is loss of motion early, and that happens sometimes when you operate too early. Other issues are hardware failure, which is an early cause of failure, recurrent injuries, and then people you didn't understand had a combined injury. They may have had an ACL posterior lateral corner. You only fix the ACL. The posterior lateral corner is going to cause that to fail. Loss of motion is a devastating problem. You have a patient like this, shows up in your office. There's really not a lot to offer him except for trying to get that extension by working hard on physical therapy and maybe eventually doing our lysis of adhesions. Very ungratifying when patients show up with that kind of extension loss. So preoperatively, be aware of this. Emphasize motion, control their effusion, get their quad tone, allow them to have good gait before you operate on your ACL. This will reduce your incidence of arthrofibrosis, unless, of course, you're above 7,000-foot elevation. Intraoperatively, make sure you put your tunnels in the right location. Postoperatively, control the hemarthrosis, either with a drain or ice. Early loss of motion is an extension, is a problem. And if that's a problem, you have to do serial casting, physical therapy. If that fails, you may have to do manipulation under anesthesia and lysis of adhesions about the 6 to 12-week part. Be aware also of RSD, which is a devastating problem, also called complex regional pain syndrome now. Whenever we can't figure something out completely, we just rename it and that solves the problem. So we now have complex regional pain syndrome. You can also have fractures or patella tendon ruptures. This can be reduced by using a smaller saw blade, cutting the undersurface, drilling holes at the corner, making a less rectangular, more triangular graft, and bone grafting the defects. Also, you can have tunnel osteolysis, which means that the tunnel expands for some reason, and there may be a variety of reasons for that. That's really not too big of a problem unless you're getting into revision and they have it. As far as the other complications, there can be some proliferative tissue, such as demonstrated here at the tibial tunnel site. People think that's maybe because there was too much leftover debris when you're doing your ACL. If they have a click and terminal extension and you make this diagnosis of a cyclops lesion, you simply remove it, and that gets rid of their problem. Again, tunnel position. Howell has taught us you need to have the tunnel behind Blumenstadt's line. If you have the tunnel in front of Blumenstadt's line, then you have strain and flexion, as you can imagine. If you put the tunnel too posterior, you can have strain and extension. The other thing that Howell has taught us is to consider the coronal plane as well, by moving the tibial tunnel starting point further medial than we used to. And when you do that, then you can have less problems with graft impingement in that plane as well. From a practical standpoint, what we do is put the tibial tunnel midway between the tibial tubercle and the posterior medial edge of the tibia. And we showed in a cadaver model that does the trick. Do not shrink things. If there's one message that I'll try to share with you the rest of this time is do not shrink things. If you shrink ACLs, they'll rupture. You shrink ACL grafts, they'll rupture. In fact, they did a canine study where they shrinked 18 dog ACLs, and 8 weeks post-treatment, 100% of those 18 dogs ruptured their ACL. So if you just want to kind of tighten it up a little bit with your shrinkage wand, think again. How can we prevent ACL injuries? This has become a real big focus of study lately. And the way that you can do it is to train your athletes to not land in precarious situations. So the skier training in Vermont, they taught these ski patrol guys how to avoid falls, or when they fall, how to avoid crossing their tips, etc. And that provided a benefit. They couldn't teach the novices because the novices didn't know how to ski. So you still have a chance if you work at a ski resort. As far as a female athlete, this has been a big focus of research, and the bottom line is at least one component of risk of the high ACL injuries in female athletes in pivoting sports such as basketball and soccer is jump training. So we've taught the women to try to land in more flexion and less valgus and to absorb the energy, and that's reduced the number of ACL injuries in a female athlete. And so neuromuscular training and plyometrics has proven to be beneficial, particularly in that population. ACL bracing does not have a prophylactic effect, with the exception of one study in skiers. And so ACL brace is really not the solution. Moving on to the PCL. PCL, again, gets injured by a blow to the proximal tibia, or you can have a hyperflexion injury which can cause this. Hyperflexion injury, PCL injury. Again, the key exam is the posterior drawer. The key to that is recognizing the normal step-off. Treatment of PCL injuries, somewhat controversial. What is not controversial, if you have a big bony avulsion off the tibia, that needs to be fixed. And the way you do that, you put a screw and washer and fix that primarily. Isolated PCL injuries, grade 2 PCL, doesn't go behind the medial femoral condyle, then in that case, those should be treated non-operatively, especially for your board examination. Isolated PCLs treated non-operatively. Quadriceps rehabilitation, maybe an initial period in a brace and extension, non-operative management of isolated PCL injuries. The problem with non-operative treatment of PCL injuries down the line, again another testable issue, is they're going to get arthritis in the medial femoral condyle and the patellofemoral joint. Medial and patellofemoral arthrosis, common long-term sequela of a PCL-deficient knee, has to do with altered contact pressures. And then if you have combined injury, PCL posterior lateral corner, PCL ACL, anything that's a combined injury with the PCL, most authors would recommend reconstruction, much less controversial. Multiple ways to do PCL reconstructions. The traditional technique is arthroscopic, where you go transtibial from front to back. The risk there, of course, is the popliteal vessels. The tibial inlay technique, which I prefer, involves mobilizing the medial head of the gastroc and approaching it directly in the back of the knee. And then either of these techniques can also take advantage of two bundle techniques. Two bundles implies two bundles in the femur. And so the anterior lateral bundle, which is the most important bundle, again, in flexion, and then the posterior medial bundle, which is less important, but it's important more in extension. Postoperative from PCL, immobilize an extension. Recognize that gravity is your enemy, and therefore do your motion with the patient prone or on their side and supported. And emphasize quadriceps rehabilitation. We do know that the inlay method has less graft attrition than the traditional method, and this has been shown biomechanically in 2 separate studies about 4 years ago, so they're in the test-taking time period for you to be aware of it. And recognize then that the transtibial technique can cause graft attrition. Recognize also, probably 2 years plus out now and testable, is the 2-bundle technique has better stability. Well, how about moving on then to medial collateral ligament injuries? As I tell my patients, this is the one injury that your body can successfully take care of the 4 ligament injuries in the knee. So they're lucky if they have this injury. Mechanism of injury, valgus contact. Exam, open only at 30 degrees. If they open also at 0, then their body's not going to take care of it because they've got a cruciate ligament also. Treatment for an isolated MCL injury is a hinged brace for 6 to 8 weeks. They're not going to get into this controversy about what degree of flexion you allow initially and later. It's just a hinged brace. So treatment for isolated MCL, hinged brace. If you have a combined ACL-MCL injury, then you need to recognize either delay your ACL surgery till the MCL heals up, or recognize that the patient is at risk for loss of motion if you do an ACL during the time period their MCL is healing, and emphasize motion all the more. Lateral collateral ligament injuries is exceedingly rare. I have done over 200 knee dislocations. I have never seen an isolated lateral collateral ligament injury. But I have seen that injury very commonly with multiple ligament injuries. But by itself, it's very rarely injured. Now, the mechanism of injury theoretically then would be a varus contact injury, should open up only in varus. But again, isolated injuries, be very suspicious that there's something else going on, particularly a posterior lateral corner injury. And here's what we see more often than not, is this bomb that goes off in the posterior lateral corner from a posterior lateral corner injury. A seemingly benign appearing injury until you open the skin and see the devastation that occurs from injuries to the biceps, the iliotibial band, the popliteus tendon. It's unbelievable. So this occurs as a result of rotational injuries. As I indicated, it's often combined, especially with PCLs. And if you don't recognize this, then you're going to have failed ACL reconstructions, failed PCL reconstructions, and other problems. Again, the key is external rotation asymmetry or dial test. Other associated exam includes external rotation recurvatum, where you grab the big toes while they're laying supine, and the knee will fall into varus and hyperextension. The posterior lateral drawer, where the tibia not only goes posterior, but rotates posterior laterally as well. The treatment then for posterior lateral corner injuries is to try to repair what you can primarily and then supplement this. Supplement with a free graft, and that seems to work the best. New emphasis has been to also try to reconstruct the popliteal fibular ligament, or this arm of the reconstruction that connects the fibula to your popliteus graft. Multiple ligament injuries, the most important thing here is to make sure you assess for neurovascular injury, number 1, and number 2, reduce the knee. So they'll often ask you what the treatment is, and if the knee's been assessed and it's still dislocated, then reduce it. It's pretty simple. That's a gimme. So the name of the dislocation is based upon the direction of the tibia. The more distal bone always describes the location of these dislocations. Treatment again, assessing the neurovascular status, reducing it, reassessing their vascular status. If there's any question, you need to get vascular surgery involved with either high-tech non-invasive studies or arteriogram, which is the gold standard. Unusual injury, therefore often asked on tests, is the tib-fib dislocation. If you happen to ever see this, then you should reduce it and then immobilize the patient in extension. And because it's an unusual injury, that's all you really need to know. Bioabsorbable materials, certainly we're aware of polyglycolytic acid, which is what the SureTac was made of. It absorbs very quickly. PDS takes a couple of months, and that's why a lot of companies are switching some of their knee meniscus repair implants into PDS rather than PLLA because it absorbs more quickly. PLLA takes a long time to absorb. Have you ever been involved in a revision ACL reconstruction and you still see a screw that was placed 8 or 10 years ago? That's because this stuff may not ever absorb. And then there's various hybrids coming along now to try to get the PLLA to absorb a little more quickly. What about our favorite problems like patella tendinitis? Well, this occurs at the inferior border of the patella, very common in jumping athletes. They'll have pain right below at the bottom of their inferior border of the patella, right there at the patella tendon location. It will diminish if their knee is flexed or they tense their quads, patella tendonitis. Treatment with Chopat strap, which is a strap that reduces the tension across it, modalities, etc. Quadriceps tendonitis, the pain's in the superior aspect of the patella, less common, same problems. Prepatellar bursitis, the key question here is the fact that this occurs in wrestlers, and they want you to aspirate it. So the key test question on prepatellar bursitis in a wrestler is to aspirate that bursa. Iliotibial band syndrome, very commonly asked, occurs in hill runners. The exam is the Ober test. You place the patient on the side, the symptomatic leg up, abduct, extend, and then take it to a position of adduction, and you'll see tightness in that area or clicking or pain. In that case, you give them an injection, and that usually takes care of it. Rarely do you have to do a surgical excision. How about our friend, the new complex regional pain syndrome? The key here, the key testable item is disproportionate pain. Pain out of proportion to what they should have. And the other key testable question is the treatment also confirms the diagnosis. So an epidural or sympathetic block will not only get rid of the pain, it'll make the diagnosis. And then there's other things that can be tried, including alpha blocking agents. Extensor mechanism of injuries can occur. We've already heard this. If you're over 40, you get a quadriceps tendon rupture. If you're under 40, you get a patella tendon rupture. It is amazing how true those numbers really turn out to be. I do a fair number of both of these, and it's very true how the patella tendon occurs in the younger patient. Patellar fractures, you've got to treat it if it's displaced. Patella dislocation, again, the key here is the MPFL as the primary restraint, and it's probably too controversial to talk about acute reconstruction of that. For recurrent instability, the key is examination, apprehension, looking at radiographs for congruence, and then treatment of almost any patellar instability thing you'll see on the board is if you haven't had a lot of rehab, then you better order more rehab because the treatment otherwise is a little more controversial. Occasionally you have to do realignments. If you do, recognize that a Fulkerson is contraindicated in a patient with superior medial arthritis. The reason is because it will concentrate that area more and cause them even more pain. So before you consider doing a Fulkerson, stick a scope in and look at their patella. If they have superior medial arthrosis, bail. Lateral patellar compression syndrome. Another thing that you should not have a lot of on your board list for part 2 is lateral releases because they are significantly overdone in this country. There's nothing worse than the kids come back from college from spring break where you have a half dozen post-op lateral releases you have to take care of. It's horrible because the surgery was never indicated. The only indication for a lateral release is if you have objective evidence of lateral tilting and refractory extended rehabilitation. That's the only incidence of it. You don't do it because, well, I didn't find anything else wrong in the knee, and so I thought I'd do a lateral release. That's not a good answer. All right, patellar chondrosis. Again, you can see this on radiographs. The treatment's rehabilitation. Occasionally, you can do a tubercle elevation, which is called a McKay procedure, which got a bad name because it caused skin necrosis in the proximal tibia. The reason is because McKay indicated you raise it up an inch, so obviously it's going to cause skin problems. In fact, if you do a McKay nowadays, you should only elevate it a centimeter, and more often than not, people are doing Fulkersons, which really effectively does the same thing by sliding it up the slope of the tibia, and you can stick some extra bone graft underneath that if you want, and do an elevation of the tubercle for refractory patellar chondrosis. Patellofemoral syndrome, pain with stair climbing, pain with sitting for long periods, exam, compression of patella, treatment, rehab, 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 rehab. Try to avoid operating on these patients. The so-called miserable triad, as characterized by Jesse DeLee, involves femoral anteversion, genu valgum, and external tibial torsion. The reason it's miserable is not only for the patient, but for you in clinic. How about some of these pediatric disorders? Well, there's two sides of the patella. You can get it on the tibial tubercle side. You get Osgood-Schlatters disease, self-limited process. You simply do conservative management. Signe Larsen-Johansson occurs in the inferior part of the patella, same concept. rest, activity modification, non-steroidals, etc. About physeal injuries, the key test question here, two test questions. Number one, diagnosis with stress radiographs when you're not sure. Number two is that these injuries, although they appear relatively benign initially, can be devastating and cause significant growth problems, even with minimally displaced fractures. So you've got to counsel the patients and the parents. The other thing is ligament injuries. You can have a medial tibial spine or medial eminence avulsion, and that's the classic 1, 2, 3 categorization you see. And so the classic answer is you put them in extension. If it reduces, fine. Put them in a cast. If not, then you have to do surgery. And more often than not, though, you do need to do surgery because the lateral meniscus or intermeniscal ligament gets displaced in there and it keeps you from reducing it. And therefore, treatment would be to fix that with a variety of techniques. You can either use sutures and pull it down through small drill holes, or you can put a screw in that stays above the physis, an angled screw that stays above the physis. The key is to not put screws across the physis whenever you can. Now, unfortunately, more and more we're seeing really young kids, 10 years old, with mid-substance ACL tears, and this is a controversial area as well. I think you're best on your boards to avoid any tunnels in these really young kids, especially in the femoral side. A central tibial tunnel is probably okay. That's been shown to be okay. But a femoral tunnel is eccentric, and it may cause growth problems, and so therefore the treatment for these is a physeal sparing operation of the distal femur and a soft tissue graft for these young kids. So here's a case where we make a very vertical 6 millimeter tunnel past a hamstring graft, not through a femoral tunnel, but over the top to avoid violating that physis. Be aware of patellar sleeve fractures. This is fortunate on this exam because you actually saw the piece of bone. But if you see a really high patella alta and you don't know why, this may be a reason. So a young kid with a patella alta probably had a patellar sleeve fracture. An older patient with patella alta probably had a patella tendon rupture. So you're taking your boards, you look at an x-ray and you go, I can't see anything wrong with this thing. Look at the height of the patella. That may be the issue. Other problems, the popliteal cyst in the young patients often asked. And the bottom line is this is a spontaneous resolution. You don't need to go in and drain that cyst or remove that cyst. Baker's cyst and the kids will go away. Bipartite patella, again, superior lateral aspect of the patella. Observe these because rarely they're truly symptomatic. If there's some question, you do a bone scan and see whether it's really injured. Let's do some knee questions. Now, wrong answers for a knee question is when you order MRI without having a reason for it. Giving steroid injections is usually not encouraged for board answers, nor is using RF frequency for burning things. The role of diagnostic arthroscopy is not hot on the boards. In other words, you should know what you're doing before you get in there. You don't do ACL repairs. You do ACL reconstructions. You don't do ACL reconstructions acutely because you get arthrofibrosis. Keep in mind, this is a very conservative people writing this test. You don't initially do operation for grade 2 PCL injuries, isolated PCL injuries treated non-operatively. And you don't operate on patellofemoral unless you've tried extended rehabilitation. So what we're going to do is go through these questions. We're going to cover the odd questions. I'll leave the evens for you later. So, odd questions. Number one, which of the following describes the components of the posterior cruciate ligament? Posterior cruciate, remember we talked about it being your pal. Anterior lateral is tight in flexion. So, which of the following statement best describes tension in the components of the PCL with the knee taken from extension to flexion? Okay, well our pal, we know our pal is loose in extension and tight in flexion. Okay, so ACL, let's go through, what do you think? ACL, anterior lateral band, PCL, anterior lateral, pal, lax in extension, tight in flexion. Posterior medial tight and becomes lax. They have a reciprocal action. Again, PCL, pal, anterior lateral, tight in flexion. Skipping 2, going to 3. College football player twists his knee, making a tackle. No medial laxity or joint line tenderness. Doesn't have meniscus tear or MCL. Anterior, posterior drawer tests and pivot tests are negative. Okay. Doesn't have a PCL. However, the Lockman's positive. What's the diagnosis? ACL. Skipping 4 and going to 5. 13-year-old quarterback feels a pop. Radiographs and Lockman are normal. has tenderness over the distal femoral physis. 13 years old, physis. How are we going to figure this out? Stress radiographs. Skip 6, go to 7. What part of the meniscus has the highest incidence of degenerative or complex tear? Older patient, complex tear of the meniscus, posterior horn, medial meniscus. Skip an 8, go to 9. Joint line cysts. Lateral meniscus tear, horizontal cleavage, more often than not. Skipping 10, note 11. 13-year-old boy. MRI has an OCD, open physis. OCD, open physis. A little bit of effusion, not too symptomatic. What are we going to do about that? Open physis, don't treat it. Activity modification, take a look at them in a couple months. Only if they failed extended non-operative management or significantly symptomatic with open physis. If this had closed physis, it might have been a different answer. But open physis, it still has a chance to heal. 13, gait pattern, ACL deficient knee, quadriceps avoidance. 15, soccer player, knee injury, grade 3 ACL, MCL, also lateral meniscus. He has the new O'Donoghue's triad, ACL, MCL, lateral meniscus. O'Donoghue described ACL, MCL, medial meniscus, but now we know it's more commonly this triad. So if you delay ACL surgery, what are you going to reduce? Medial side injury, high risk getting stiff, so you reduce the arthrofibrosis. 17, 23-year-old football player, hyperflexion injury. Hyperflexion injury. That's the key to this whole question. Hyperflexion injury is a PCL until proven otherwise. 19, describe the relationship of the tibia and the femur with a positive reverse pivot shift. Well, the reverse pivot shift starts in flexion. Therefore, we know that the PCL with the knee inflection should be subluxed. Wrong, wrong, wrong. Hey, let's look at this. Subluxed posteriorly with flexion reduces an extension. That sounds good to me. Okay? See how easy it is? Those are the same questions you blew off because you couldn't figure them out before. 21. 32-year-old man, swelling in the knee, fell on the knee with the foot in plantar flexion. Let's see, foot in plantar flexion. Where did the force go? Did it go to the patella or did it go to the proximal tibia? Lockman test, apparent increase in anterior translation. Well, that's a pseudo-Lockman because the starting point's the issue. Passive external rotation at 30 and 90 is equal to the contralateral side. Negative dial test. Doesn't have a posterior lateral corner injury. Quadriceps active test is positive. They love that test for some reason. That means that the PCL is injured. Okay, so yada, 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 the guy's got a PCL injured. He's got an isolated PCL injury. How do we treat that? On the boards, physical therapy, quadriceps rehab. 23. Cadaver studies show that alteration of joint kinematics following PCL injury leads to arthritis. Fujifilm studies all show arthrosis or increased contact pressures in the medial and patellofemoral component. Medial patellofemoral compartments. 25. Which of the following on physical exam best indicates an isolated posterior lateral corner injury? Okay, remember, isolated, not a PCL. Okay, isolated 30 degrees, right? Not 90. Here we go. 30 degrees. 27. 25-year-old man struck by motor vehicle, sustains an injury to the right lower extremity, posterior knee dislocation. They did their neuro exam and it's intact. Now what do we do? Well, the guy's sitting there with a dislocated knee. What are we going to do? Well, let's reduce it, and then we'll do the rest of what we need to. Okay, pretty simple. 26-year-old marathon runner, hill training. Hill training always means iliotibial band syndrome. Hill training, iliotibial band syndrome, always. Ober's test. That's the only reason you do the Ober's test is iliotibial band syndrome. So you got two reasons we're talking about iliotibial band syndrome. Hill training, Ober's test. Iliotibial band. 31. RSD, what is the most common indicator? Disproportionate pain. What's the treatment? Sympathetic block. What's the diagnosis confirmed by? Sympathetic block. 33. What is the most appropriate indication for lateral retinacular release? The answer is not the kid's home from school and he's going back to see Dr. Miller. Lateral patellar compression syndrome following physical therapy and associated lateral tilt. Tried therapy, has objective evidence of tilting, then and only then is a lateral release indicated. 35, 6-year-old girl, painless popliteal cyst. Just watch it. Okay, so now we still have some time because lunch isn't going to be ready yet, so we're going to jump into the lower extremity. I know that we're usually break for lunch at this point, but today we're not. If we break right now, you will get no lunch, so we're going to press on. All right, moving on to the lower extremity, the first thing is a very confusing thing called athletic pubalgia. We're still trying to figure out what this means, and therefore it's not all testable. We do know that you can have lower abdominal or inguinal pain at the extremes of exertion, occurs more often in males, particularly hockey players, and there may be a problem at the adductor longus, and it can occur with valgus, with Valsalva maneuvers or stress and sit-ups. Treatment is conservative. I don't think the board at this point is going to ask you to recommend a hernia operation for an orthopedic surgeon, so don't worry about it, but that's what's going on. Sports hernia, same sort of thing. Again, we haven't figured this out. There may be a fascial defect in that area, and more you're seeing endoscopic repairs and other repairs in these athletes. Again, probably not appropriate for us in this board exam. A variety of other things include rectus femoris tightness, adductor strains, all treated non-operatively. Osteitis pubis, they may show you an x-ray of a pelvis. If you look at an x-ray of pelvis and you can't see any fractures, look at the pubis, see if it's osteolytic, and that'll help you make that diagnosis. How about snapping hip? I know this was mentioned in the radiology lecture, and I agree there's 3 kinds. One, external, that's the iliotibial band, not the iliotibial tract, but really the fascia lata up here. Band and tract are more distal, but the fascia lata is up here at the hip. And that's what gets tight, and the treatment for that is conservative management, and occasionally you have to do a release. Now, interestingly, traditionally it's called a Z-plasty, but recently Burr described doing this kind of cut where you make this transverse cut in 2 other cuts, and then when you do that, it completely releases the tissue. And this is, if you ever run into this problem and it's failed conservative management, this is a good way to go. This works out really nice. I've done this a couple times now. Now, internal snapping hip is because the iliopsoas, it snaps over the imminence there, and you can see that on bursography. And so the recommendation is do a bursogram. And if that shows that it indeed is positive, then you can do a release. Now, you probably want to send them somewhere else to a release unless you're very familiar with this area. Interesting, Tom Berg down in Nashville is doing this through a iliopsoas bursoscopy. So he's doing it through the scope. Not me, brother. But anyway, that's what he's doing. Now, the other third kind of, anyway, for the boards, the treatment is to lengthen it if it fails conservative management. Probably open. Now, the third option is an intra-articular thing, which you'll see with an arthro MRI, maybe a labral tear or loose body. And therefore, the treatment is hip arthroscopy. How about hip subluxation and dislocation? Well, most of the time, if you have a hip injury, it goes posteriorly, as you know. What happens, what's a little unusual in sports is this hip subluxation issue, so-called Bo-Jackson syndrome, where you had an injury to the hip and it momentarily subluxed and then immediately reduced. And the key here is to have a high index of suspicion, because if that happens, there's a high risk of osteonecrosis. And so what this recent JBJS article, probably 2 years ago now, recommended would be to get a oblique x-ray, Judet views, obturator obliques, and to see if there's a tiny injury to the posterior acetabulum. If there is, then they recommend considering doing an aspiration of the hip, because the blood in that hip can cause avascular necrosis of the hip. And so that would be something to be aware of. Greater trochanteric bursitis, those usually respond to steroid injections. Hip arthritis is something that comes up, and the key exam question in the sports world for hip arthritis is, what do you lose first? And the answer is internal rotation. Hip arthroscopy, there's 2 different ways to do it, either lateral decubitus or supine, and it's beneficial for loose bodies, labral tears, etc. The key here is whenever you're considering doing arthroscopy on unusual joints or joints with a lot of nerves around the area, is to know what those nerves are, because that's what they love to ask on these exam questions. And so if we're doing a hip arthroscopy, some of these old guys probably think that's crazy, and they're going to ask you then about injuries. And so be aware that the anterior lateral portal has a risk for the superior gluteal nerve. The posterior lateral, if you straight to posterior, has a risk for the sciatic nerve. And the anterior portal has a risk to the lateral femorocutaneous nerve and even the femoral nerve itself. And so if you're going to see a hip arthroscopy question, it's probably going to be what kind of arterogenic injury you can cause, these nerve injuries, and articular cartilage injury. How about stress fractures? Well, we talked on this in the radiology lecture. Again, very common problem, and MRI is gradually supplanting bone scans in this area. And it's important to recognize the key treatment for stress fractures is to avoid activities or reduce activities. And so key test questions on the femoral neck, looking on MRI and seeing which side it's on, okay? The compression fractures you can be a little more conservative with on the inferior surface of the neck. The tension fractures on the superior surface of the neck, be very aggressive about recommending putting screws in there because otherwise it'll displace. The femur, they recommend a fulcrum test, which is basically you stress that across a kind of a three-point bend, and if that's painful, then obviously you want to limit your activities. The tibia, the question here is about the dreaded black line, which on a lateral radiograph you see a black line through some sclerotic anterior cortex. The treatment for that is recommended is to put a rod down it. The navicular is a very commonly asked test question on stress fractures. Tarsal navicular, if you see a linear line going through that, then you should put a screw across it. If not, then the answer is non-weight bearing. That's one of the bones that you treat non-weight bearing. How about some of these other shin splints? Well, medial tibial stress syndrome is probably the most common of those. And the pain decreases with running, which is a little unusual, and so that helps you differentiate that from exertional compartment syndrome. Exertional compartment syndrome asks on a lot of examinations because of its several things that are eminently testable about this, including the requirements for making the diagnosis. And again, the biggest requirement for making the diagnosis is an increase in pressure by doing exertional testing, put them on a treadmill, stick them with a Stryker evaluation, and you can see that after exercise, a minute after exercise, if the pressure stays above 30, then that's diagnostic. Treatment then, activity modifications, et cetera, but most of these kids aren't very successful in non-operative measures, and then you have to have a discussion with them about treating them. Now, unfortunately, this is not a home run operation, and I tell this to the kids all the time because I see a lot of this, a lot more than I want to. But the bottom line is you tell them it's not a home run operation because there's a lot of overlying conditions that can be mimic this. Stress, shin splints, stress phenomenon, stress fractures, etc. And so if you have the diagnostic criteria clearly set out, then you have a counseling discussion about all these other problems, and then sometimes you have to do the surgery anyway. And if you're doing the anterior compartment, usually it's successful. But if they have other compartments involved, it's not always successful. So again, the take-home answer, anterior compartment most often affected and has the best results of treatment, and the treatment is to release the fascia. But if you have other compartments, not always as successful, and there's other overlying conditions that can make your treatment suboptimal. So you don't want 20 of these on your boards. How do you do it? Well, from a practical standpoint, we like to go about 12 to 15 centimeters above the tip of the lateral malleolus on the lateral side, and that allows us to see the superficial perineal nerve where it exits and protect it, because that's a risk, superficial perineal nerve risk. And so sometimes there will actually be a fascial hernia in that area, and that's gratifying because if you release above and below that fascial hernia, that'll give them good relief. Keep in mind that that superficial perineal nerve is right about at the junction of the anterior and lateral compartments, and therefore after you isolate that nerve, you can release just both above that anterior compartment and below the lateral compartment and get both the anterior and anterior lateral compartments released if those are affected in your studies. In order to release the posterior compartments, you have to make a medial incision. And that is typically done about the middle of the tibia, right below the level of the tibia. And you can release the superficial posterior compartment just by releasing the fascia there. In order to release the deep medial compartment, you actually have to elevate off the back of the tibia. And so that can be a little scary, so you've got to be a little careful with that. How about this really weird thing called popliteal artery entrapment syndrome? Patient may present with intermittent claudication, diminished pulses, and you do an arteriogram, and if that's the case, then you can release the medial head of the gastroc and release this constriction. I have never seen this except on multiple examinations. How about other nerve entrapment syndromes? Well, there's some weird ones out there, and weird things get tested a lot. One of them is a surfer dude who complains of knee numbness on a regular basis, and what happens is they're paddling their board all the time on their knees, and the saphenous nerve gets impinged as a result of that, and so that's called surfer's neuritis, saphenous nerve problems. And the treatment then is buy them some knee pads. Superficial perineal nerve, again, can get entrapped in that same place you're doing those lateral releases. Lateral plantar nerve, the foot guys probably hit this too, but this is always asked because it's Baxter nerves, and it's a nerve to the adductor digiti quintae, and that is entrapped in the abductor hallucis fascia, and so you have to do a release to release that fascia. Medial plantar nerve, that can be entrapped as well. The key exam for this, they'll always tell you somebody's wearing a foot orthotic, and it makes it worse, okay? That's because the foot orthotic is pushing on that nerve, making it worse, and so the answer is medial plantar nerve, get rid of the foot orthotic. How about muscle injuries? Well, these are very common, of course, in day-to-day life, and the thing that sometimes occurs is the question about fatigue, muscle fatigue. This reduces the muscle's ability to absorb energy, and so therefore makes it more susceptible to injury. Hamstring injuries, they occur anywhere up and down the back of the thigh. Quadriceps contusions, severe quadriceps contusions, as shown by 2 separate studies from West Point, are treated with the knee in flexion overnight. So you flex the knee up, you put an ACE wrap around there, and flex the knee overnight with a severe quadriceps contusion. The gastroc soleus complex can be injured, and I know for a fact that Tim Sanders talked about this tennis leg being occurring as a result of the plantaris tendon. Well, most of us feel it's really the medial head of the gastroc that's injured rather than the plantaris tendon. At any rate, it's treated with conservative management. The one time you operate on hamstrings injury potentially is when it's pulled off of the ischial tuberosity and significantly displaced. Garrett and others have described this in water skiing injuries where the water ski gets caught. And if you have a water skier that's avulsed and they show you an MRI, then early repair is recommended for that. How about myositis ossificans? This is a result of direct trauma. The key here is to differentiate this from a tumor. And the key there is to recognize mature bone is at the periphery. Remember that beautiful CT scan that Dr. Sanders showed you where you had that egg and that periphery had a mature bone at the end of it. So the treatment for myositis ossificans is active range of motion, not passive, but active range of motion. And the other thing is to wait and see how it matures. Don't go operate on it in the acute phase. You'll just piss it off. So wait until it matures. If it's a problem, then you can excise it. We've had some interesting football players with this that have just horrible x-rays, but didn't bother them, and they left it alone wisely, and they did fine. Variety of tendon injuries in the lower extremity, and we'll go through those. Perineal tendon injuries, the main thing you can have is this popping out of its behind the lateral malleolus. If that happens when you do a eversion, you have the patient evert against resistance. If they pop it out, then they may want to have it reconstructed. This is what Barry Foster had, the football player for Pittsburgh. And the treatment then is to try to reconstruct it by putting it back behind the fibula and reconstructing then this cartilaginous ridge that allows it to stay in. You can try to do that acutely if you can. Otherwise, you'll have to swing some tissue in there to do that, or deepen the groove to keep it in there. Okay, so that's subluxation or dislocation of the perineal tendons. Now, also very commonly happens, especially with the peroneus brevis, is longitudinal tears in that. That may or may not be associated with the same problem. If you see that, then the treatment then is to debride it and repair those tendon tears. Posterior tibialis tendinitis got a lot of press in the sports world because Rich Hawkins wrote an article about it, but the treatment is the same as in the foot world, so there's nothing special. The bottom line is you just debride or reconstruct the FDL, excuse me, with a FDL or FHL transfer. So debride it and then transfer either part of FDL or FHL. Well, there's some other weird tendon injuries, the flexor hallucis longus. The reason this is a fun one is because the exam. The exam is reported to have decreased great toe passive extension in neutral, but when you put in plantar flexion, you have normal great toe passive extension. And because that's such a weird exam, it appears on exams. And so if you ever see something weird about that, some kind of toe, foot position thing, big toe, the answer is big toe tendon. Never seen it. Okay, Achilles tendonitis. This is an overuse injury, and therefore the treatment in most cases, especially for the boards, unless you're Patrick Ewing, is rest and therapy. As far as ruptures, well, we know the classic teaching on this, and that is that if you treat it closed, you have an increased re-rupture rate. If you treat it open, you have risk of skin slough. And so the answer is to be very careful with our skin incisions and avoid the sural nerve and make nice flaps. How about the os trigonum, os subfibulaire, and os perineum? Well, the key here is the os trigonum. This occurs when you're a ballet dancer on your tiptoes, which is called en pointe. And if it fails conservative management, then you can excise it. Os subfibulaire is just a little piece of bone off the fibula, subfibulaire. All it means, its only significance is that it has association with chronic ankle instability because it probably wasn't involved in the ATFL in the first place. And so it's associated with ankle instability. Os perineum, the only significance here, again, this occurs near its fifth metatarsal base insertion, is if it's displaced proximally, it may have been associated with a peroneus longus rupture. Ankle sprains, very common. We see this every day. The ATFL is the most common injury. And the key test question in these ankle sprains is what the foot position is. If the foot position is plantar flexion, it's an ATFL injury, either in the mechanism or in your exam. If the foot flexion is in dorsiflexion, then it's a CFL injury, either in the mechanism or the exam. So think about the foot position, and that's the only thing they're going to ask you about this. Now, as far as high ankle sprains, it's important for you, if you're a high school or college or pro doctor, is to tell the coach how long that guy's going to be out. And so you need to recognize this so-called high ankle sprain by having a high index of suspicion and doing external rotation stress tests, squeeze tests, and try to figure out whether they have proximal fibula tenderness, because they're going to be out longer than with a regular ankle sprain. When do you get an x-ray in the training room? Well, the Ottawa Ankle Rules attempts to answer that question. If you have an inability to walk and you have tenderness in these locations, that is the distal and posterior fibula, fifth metatarsal base, like a Jones fracture, navicular, highly associated with stress fractures, then you get an x-ray. And you can also do stress radiographs to try to see if you have ankle instability, objective management, comparing it to the contralateral ankle. You can test for syndesmotic injuries by external rotation stress test. Look at the mortise on that test. If you have significant asymmetry and opening, you may want to consider putting a screw across there. MRI is very helpful also in looking for perineal tendon pathology and osteochondral injuries as shown here. Ankle sprains, treatment, rest, ice, compression, elevation, strength and proprioception training, only surgery after extended non-operative management with strengthening and bracing. And then the surgery most people recommend is an anatomic reconstruction, which is a Brostrom operation, which basically involves an imbrication of the tissue or advancement of the tissue. And sometimes people will recommend arthroscopy for recurrent ankle problems and pain after ankle sprains. And there you may see various meniscoid-type lesions, which just means some fibrous proliferation and pinching of the fibrous tissue in the joint. So the question is, how long will your athlete be out? Well, it depends upon the degree of injury, whether they have a syndesmotic injury, whether they have associated injuries, and how much rehab they've done. So let's talk about that. They have various grades of ankle sprains. It depends upon what your tear. The smallest one tears the ATFL. The second degree tears the ATFL, but intact CFL. Well, how do you figure that out? Well, again, it depends upon the foot position where you're doing your tilt testing. And then complete ATFL and CFL, they're out for the longest probably. Do they have a syndesmotic injury? Again, external rotation, provocative testing, squeeze, abduction, external rotation, single leg hop, and then that'll keep you out longer. The other thing is how high up the fibula they have tenderness. If it's higher up the fibula, the longer they're out. The other issue is whether they have associated injuries, osteochondral defects, peroneal tendon injuries, fractures, etc. So back to the original question. How long are they out? Well, if you have a grade 1 or 2, just a week or two. A grade 3, a few weeks. A syndesmotic injury, you need to tell the coach he's going to be out several weeks, or you may be out several weeks. And if you have a severe syndesmotic injury, we have to put a screw across it, they're very likely out for the season. How about surgical management for ankle instability? Well, there's over 80 surgical procedures that are described. Whenever that happens, you know that they haven't figured out the best one, with the exception of the modified Brostrom, which is an anatomic reconstruction. So most surgeons will recommend trying this first, and most of the time it's successful. If it's not, then you may have to do some other type of reconstruction involving free tendon grafts. Again, ATFL, the torn ends are imbricated and sutured. You can also advance these up to the bone and advance them onto suture anchors if you're so inclined. Again, the arthroscopic impingement lesions can occur at various locations, and they're all a sequela of ankle sprains and may benefit from arthroscopic debridement if all else fails. Prevention of ankle sprains involves various orthoses, strengthening, and proprioception exercises. Let's move on to tibio-talar impingement syndrome. Pain when the foot is dorsiflex. You may see a spur as shown here on lateral radiographs. Treatment, arthroscopic excision. Lower extremity fractures has been touched upon already. Proximal femur, so-called skier hips, nothing more than a proximal femur fracture. Ankle fractures, you've got to be concerned about articular cartilage injuries. Proximal fibula fractures can be associated with ankle injuries. And the so-called snowboarder's ankle, which gets into my talk because snowboarding is a sport, this is associated with a lateral process, the talus fracture. And as we've discussed, a big piece needs to be fixed because it's got articular cartilage on it, and it'll get arthritis if we don't fix it, especially when it's displaced that much. How about osteochondral injuries? Again, on the medial side, they're deeper and more posterior, harder to get to. That's why you sometimes have to do an osteotomy of the medial malleolus to get access to it. On the lateral side, they're more superficial and shallow. Treatment, arthroscopic, and again, for purposes of the board, the most likely treatment option is to do a debridement or a drilling. Okay? Don't worry about other cartilage procedures. Ankle arthroscopy, again, I told you, arthroscopy, guys are going to want to know about complications. So make sure you know these complications. It's probably the most important thing you can review for arthroscopy. In the case of the ankle, you can get in trouble on anterolateral portal because you can risk the superficial peroneal nerve, which in fact is one of the landmarks for your portal. So the way you avoid that is you feel the peroneus tertius and try to go just adjacent to it and do the nick and spread method. Make a small incision, take your hemostat and spread so you don't involve that nerve. On the medial side, well, you have the saphenous vein right there. Now, from a practical standpoint, you should mark out that vein before you put your tourniquet up, because you're not going to know where that vein is after the tourniquet's up if you exsanguinate the limb. So take your pin before you put the tourniquet up, mark out where that vein is, put your tourniquet up, and then make the medial portal between the tibialis anterior and the saphenous vein that you've marked out. The other risks for ankle arthroscopy include synovial-cutaneous fistulas, and that's true for any joint you scope that's relatively thin skin around it, such as the elbow as well. And so therefore, after you do an ankle scope, you should put the patient in a protected orthotic or a cast or a splint for a week or so after that to reduce the risk of those fistulas. So you can visualize all these structures with the ankle arthroscopy. You really can't visualize the ATFL too well. Plantar fasciitis, pain in the plantar fascia treatment rehab, stretching, 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 stretching. And probably the guys that write the test questions of the boards are not wanting you to put a scope into the plantar fascia. So keep that in mind. How about fractures? Again, stress fracture is very common with recruits or ballet dancers. The base of the fifth metatarsal we've talked about. In athletes, that is competitive athletes, then treatment may be intramedullary fixation with a screw. In a non-competitive athlete, you simply treat this non-operatively like you would in grandma. Okay? So competitive athletes, you put a screw in it. Non-competitive athletes, you simply do it non-weight bearing and allow that to heal up. That allows you earlier return to training in your competitive athletes. How about turf toe? Mechanism forced flexion here, and it can injure the plantar sesamoid complex. And unfortunately, this has been the ruin of many a competitive athlete in football is from that little big toe problem. But it can be devastating. And so the treatment initially is to try to do it non-operatively, but more and more of these competitive athletes are having these plantar sesamoid injuries repaired and may allow them to return to play. For the boards, however, recognize it's incompetent plantar sesamoid complex and that most of those are treated conservatively. If they develop problems down the line, the sequela is hallux rigidus, arthritis of that joint. Let's go on to some questions and then we're going to break for lunch. Again, we're going to go with the odd concept here. Wrong answers for the lower extremity include, again, steroid injections with the exception of the greater trochanteric bursa. Wrong answers are initial operative treatment of ankle sprains. And the wrong answer is aggressive management of recreational athletes. Again, I'm trying to make the distinction between recreational and competitive athletes in some of these injuries, particularly Jones fractures, because the treatment varies. So with that in mind, we'll go to number one. 17-year-old boy runs cross country, has deep bilateral medial leg pain. It persists 2 or 3 hours after running. He has no pain and palpitation. Radiograph's normal. What can we do to figure this out? He may have exertional compartment syndrome, which is a delayed onset, occurs when they're running and takes a while to recover from. The only way to make that diagnosis is to get him on the treadmill and stick him. Number 3, 25-year-old competitive runner, progressive pain in the medial arch of the foot. He's exacerbated by the old medial orthotic. So we talked about this. We talked about what nerves in the medial side of the foot and is exacerbated by an orthotic on the medial side, medial plantar nerve. That's not rocket science there. Number 5, which of the following rehabs should be used for the first 24 hours following a blunt injury to the quadriceps? West Point studies, immobilizing flexion. Number 7, 3 months, 35-year-old man, pain in the posterior medial ankle when running, walking, or climbing stairs. He has tenderness behind the medial malleolus. Passive extension of the great toe is greater when the foot is plantar flexed. What's that? Well, that's that weird thing about that flexor of the toe, okay? That's all you got to know, flexor of the toe. Number 9, 31-year-old woman, instability of right ankle for 10 years. Stress radiographs show asymmetric anterior drawer, excessive lateral opening, and there's our friend, the os subfibulaire. Well, what does that mean? Well, all that means is that they have a non-union fracture of the fibula from the ATFL pulling it off and recurrent ankle instability. Number 11, 17-year-old boy steps into a hole, forces his ankle in dorsiflexion. Dorsiflexion, CFL. Plantar flexion, ATFL. Which of the following is injured? CFL. 13, 20-year-old college athlete has an injury to the ankle, no fractures or widening of the mortise, swelling in the ankle, pain with lateral compression. What can you do to figure this out? You got to make sure he doesn't have a syndesmotic injury and may need to have a screw across the syndesmosis, and the way you do that is a stress radiograph. Put some lead gloves on and externally rotate the foot while you stabilize the tibia. 15. Which of the following nerves is injured with ankle arthroscopy? We know that one because it borders one of the portals. Superficial perineal nerve. 17. 18-year-old recreational soccer player, pain in the lateral foot for 4 weeks. X-ray show a fracture of the base of the fifth metatarsal. Okay, stop. Recreational. Okay? How do we treat recreational athletes like grandma? Non-weight bearing cast. 19, competitive. Competitive. Proximal shaft fracture of the fifth metatarsal. How do we compete competitive athletes? With a screw, and allows them to return to training early. 21. What's the most common sequela of a turf toe? Hallux rigidus. Great. Okay, so that really completes our review of sports medicine for the lower extremity. Tomorrow we'll talk about upper extremity. This afternoon, your schedule is exactly like it's in your syllabus. You'll have an extended period of pediatrics, and then a